All right, so we're back for another deep dive, and today we're getting right to the heart of the matter.
Literally to the heart of the matter.
Oh, yeah.
Cardiology.
So I'm Harvey,
And I'm Donna.
and we are both MCCQE reviewers.
That's right. And we know how tough this exam can be, especially for Canadian medical students.
Oh, yeah.
Yeah.
We're here to make the whole review process just a little bit easier.
Absolutely.
So think of us as your, study buddies.
Yeah.
Walking you through the material using really good sources, like stat pearls.
Yes, definitely.
Of course, before we get started, quick disclaimer. This is just for studying, not medical advice.
Absolutely.
Always talk to a qualified healthcare provider.
Yes.
Okay,
So,
for all that,
let's jump right into it.
let's imagine you're in the MCCQE exam room, you're feeling the pressure, and a question pops up about atrioventricular block.
AV block.
AV block.
Okay.
What's the first thing that comes to mind?
For me, definitely those ECG tracings we had to, go through in med school.
But before we get into all of that, can you kind of walk us through how the heart's electrical system normally works?
Sure. So think of the sinus node like the heart's conductor,
Okay.
setting the rhythm for the whole orchestra.
Yeah,
So it initiates the electrical impulse that tells the atria to contract.
got it.
And that's what we see as the P wave on the ECG.
Okay, so the P wave is the atria doing their thing.
Exactly.
What happens next?
Then the signal goes down to the ventricles, but it has to go through a checkpoint first,
Okay,
the AV node.
gotcha.
So the AV node acts as a gatekeeper, making sure the ventricles don't contract too quickly,
Right,
making sure everything stays nice and synchronized.
got it.
Then it travels down to the His-Purkinje system,
Okay.
which is a network of fibers that spread the impulse very quickly to the ventricles,
Yeah,
causing them to contract, and that's QRS complex.
makes sense. So the AV node is like the traffic controller, keeping everything moving smoothly.
Yeah, exactly.
So where does AV block come into all of this?
So AV block is basically a disruption of that nice and smooth electrical signaling. Something slows down or blocks that signal completely.
Gotcha, like a communication breakdown
Exactly.
between the top and the bottom of the heart.
Exactly. And depending on how bad that blockage is, we classify AV block into 3 main types:
Okay.
first degree, second degree, and third degree.
Okay, let's break each of those down.
Sure.
What's happening in first degree AV block?
First degree is like a tiny delay in that signal.
Yeah.
Imagine you're stuck behind a slow driver
Right.
in the fast lane.
Hmm.
A little frustrating, but not a complete standstill.
Yeah.
So on an ECG, you'd see this prolonged PR interval, meaning the signal is taking a bit longer to get from the atria to the ventricles, but it still gets through.
So all the impulses are still making it. They're taking a bit of a longer route.
Exactly.
Okay, what about second degree AV block?
Now, with second degree, things get a little more tricky.
Okay.
Some of those impulses get completely lost
Okay.
on the way to the ventricles.
Oh, so some heartbeats are going missing.
Yeah, it's like some of the musicians in the orchestra miss their cue, and you hear this dropped beat.
Okay, so that sounds kind of serious.
It can be.
Yeah.
There are 2 main subtypes of second-degree AV block,
Okay,
Mobitz type 1 and Mobitz type 2.
got it.
They each have their own specific patterns on the ECG,
Right.
and telling them apart is really important for figuring out the best way to treat it.
So I'm writing a note to myself to go over those ECG patterns again.
Yes, good idea.
What about the most severe form, the third degree?
Third-degree AV block, also called complete heart block, is a total communication breakdown.
Okay.
The atria and ventricles basically beat independently.
Okay.
It's like the conductor loses control of the orchestra and different sections start playing at their own pace.
Well, that's a good analogy.
It's a dangerous situation
Yeah.
that can lead to a dangerously slow heart rate.
It sounds like a medical emergency.
It can be.
So what causes all these different types of AV block?
There are a lot of reasons.
Sometimes it's congenital, present from birth,
Right.
maybe due to some structural heart defects, or even maternal antibodies that cross the placenta.
Okay.
But for the MCCQE, you're going to want to focus on the acquired causes.
Okay, so the ones that happen later in life.
Exactly.
All right, let's talk about those acquired causes then. What are some of the big ones to know for the exam?
One of the most common is ischemia,
Okay.
a lack of blood flow to the heart muscle.
Right. Which can happen during a heart attack.
Exactly. And that can damage the conduction system,
Okay.
leading to AV block.
That makes sense. Any other causes to be aware of?
Certain medications can also be a factor,
Okay.
especially those that directly affect the heart's electrical activity.
Yeah.
Electrolyte imbalances can also mess with the heart's rhythm,
Gotcha.
especially low potassium or magnesium. And as we get older, that conduction system can naturally wear down,
Right.
making AV block more common in older adults.
So it's a combination of external factors and just our bodies getting older.
Okay, so let's say we think a patient might have AV block. What are some red flags we should look for?
The symptoms can be different depending on how severe the block is.
Okay,
Someone with first-degree AV block might not have any symptoms at all.
right.
We might just find it by chance.
During a checkup.
Yeah, during a routine checkup or an ECG.
Right.
But as the block gets worse,
Yeah.
symptoms start to show up.
Like what?
They might feel tired, dizzy, short of breath,
Right.
even fainting spells.
Okay, that sounds pretty worrying.
It can be.
What would we be looking for on like a physical exam?
The most obvious finding is usually bradycardia,
Okay,
a slow heart rate.
right.
You might also notice an irregular pulse. And if the block is severe enough to affect how well the heart is pumping,
Yeah.
you might see signs of poor perfusion,
Okay.
like pale skin or cool hands and feet.
So the history in the physical exam can give us some clues.
Exactly.
But what's the definitive test to really diagnose AV block?
You guessed it, the ECG. It's the gold standard for diagnosing. It lets us actually see those electrical signals and pinpoint where the block is and how bad it is.
Okay. And each type has its own unique ECG signature?
Exactly.
The ECG is like a map of the heart's electrical activity.
I like that.
Are there any other tests we'd use to check for AV block?
Sometimes we'll use ambulatory monitoring,
Okay.
like a Holter monitor,
Yeah.
to catch those intermittent blocks that might not show up on a regular ECG.
Right. That makes sense. And what about like an echocardiogram? Would that be helpful?
Yeah, an echo can be helpful to look at the heart's structure and function,
Mm.
rule out any underlying problems
Gotcha.
that could be contributing to the AV block.
So it's all about putting all the pieces together.
Yeah.
The symptoms, the physical exam,
Mm-hmm.
and then the ECG is the main tool to confirm the diagnosis.
Absolutely.
Okay. So once we've diagnosed AV block, how do we manage it?
Like most things in medicine, it depends
Right.
on how severe it is and what's causing it.
So let's start with the milder forms, like first degree or Mobitz type 1,
If the patient doesn't have any symptoms,
which is often the case.
often the case, yeah, we might just monitor them closely,
Uh,
address any reversible causes.
right. Like stopping a medication that could be contributing.
Exactly.
So sometimes it's about taking a step back and addressing those things before doing anything more invasive.
Yeah, sometimes watchful waiting is the best first step.
Makes sense, but what about for higher degrees of AV block, especially when there are symptoms?
Then we usually need to step in with a more definitive treatment,
Okay.
like a permanent pacemaker.
A pacemaker. So how does that work?
It's a small implantable device, usually put under the skin near the collarbone,
Okay.
and it acts like an artificial conductor for the heart, sending electrical impulses to maintain a safe and regular rhythm.
So it's like a backup generator,
Exactly.
taking over when the main power source fails. And in emergencies, when the block is causing immediate problems, we'd use a temporary pacemaker.
Right, exactly. If someone's hemodynamically unstable
Yeah.
because of a high-degree AV block, we'd put in a temporary pacemaker
Right.
until a permanent one can be implanted.
To stabilize them.
Yeah, that provides immediate support.
Okay, so that covers the whole spectrum of management for AV block, from just watching and waiting to those life-saving interventions. All right, so let's move on to another heart rhythm disorder,
Sure.
long QT syndrome.
Okay.
What's the key thing to know about this condition?
Long QT syndrome is all about a prolonged QT interval on the ECG.
Okay,
That interval shows how long it takes for the ventricles to repolarize.
the recharge.
Yeah, to recharge after each beat.
Okay.
And when that interval is too long,
Yeah.
it can lead to dangerous arrhythmias, like
Okay.
torsades de pointe.
Torsades de pointe sounds pretty scary.
Yeah, it is a type of ventricular tachycardia,
Okay.
meaning a really fast heart rhythm starting in the ventricles.
Right. And the problem is it can turn into ventricular fibrillation, a chaotic rhythm that basically stops the heart from pumping properly,
Oh, wow.
leading to cardiac arrest.
So long QT syndrome can be life-threatening if it's not managed properly.
It could.
What causes that prolonged QT interval in the first place? Is it similar to the causes of AV block?
There are some similarities and differences.
Okay.
Like AV block long QT syndrome can be congenital,
Great.
caused by genetic mutations, affecting ion channels in the heart.
Those are the tiny gates
Yeah.
that control the flow of charged particles
Exactly.
in and out of heart muscle cells.
Those mutations disrupt the balance of electrical activity, prolonging that repolarization process.
So it's like a wiring problem,
Yeah.
causing the signals to be delayed.
Mm-hmm.
You mentioned there are also acquired causes of long QT.
Yes.
What are some of the common ones we should know?
One big one is medications. There are a lot of them.
Some antibiotics, antipsychotics, even some over-the-counter medications
Right.
can make that QT interval longer.
So medication reconciliation is really important.
It is.
What else can cause acquired long QT?
Electrolyte abnormalities,
Okay.
especially low potassium or magnesium,
Right.
and some medical conditions like
Okay.
hypothyroidism.
Can also prolong the QT interval. So again, we see that mix of external factors,
Yeah.
medications, and underlying medical conditions
Right.
that can affect the heart's electrical system.
Exactly.
How does long QT syndrome usually present? Do people have symptoms?
The tricky thing is some people with long QT syndrome don't have any symptoms at all. It might be found during a routine ECG.
Okay.
But for those who do have symptoms,
Yeah.
they can be pretty scary.
What are some warning signs to look out for?
Fainting spells
Okay.
are a common symptom, often triggered by exercise or stress.
So any situation that puts extra stress on the heart.
Exactly. Those events can be a sign that that long QT interval, right?
Is making the heart vulnerable to those dangerous arrhythmias.
Yeah. And what about family history? Does that play a role?
Definitely.
Okay.
A family history of sudden cardiac death or unexplained fainting spells,
Especially in young people.
especially in young people.
Could mean a hereditary form of long QT syndrome.
Exactly.
So that's a reminder to always ask about family history
Yes,
during a cardiac assessment.
for sure.
So if we suspect long QT, how do we actually confirm it?
The ECG is our main tool,
Okay.
but it's not just about seeing a long QT interval.
Right.
We need to take the heart rate into account
Okay.
because the QT interval naturally changes with heart rate.
Right.
A faster heart rate shortens the QT. A slower heart rate prolongs it.
So we need to adjust for the heart rate.
Exactly. We use a calculation called the corrected QT interval,
Okay.
or QTC.
Got it.
And if that QTC is prolonged beyond a certain point,
Yeah.
that's a strong indicator of long QT syndrome.
So QTC is the key measurement here.
Are there any other tests we'd use for long QT?
Sometimes if we think it's congenital, we might do genetic testing to
Okay.
find the specific mutation causing the problem. That can help us guide treatment.
Okay, so we've covered diagnosis. Let's move on to treatment. How do we manage long QT and prevent those really dangerous arrhythmias?
The first priority is always to stabilize the patient
Right.
and prevent those arrhythmias from happening.
Okay.
If someone's having an acute episode,
Like Torsity.
Torsades, yeah.
Okay.
We often give magnesium sulfate. It's really good at calming those irregular rhythms.
Magnesium sulfate. That's like a magic bullet for those acute arrhythmias.
Pretty much.
What if that's not enough to stabilize them?
In severe cases,
Yeah.
we might
Yeah.
need to use temporary pacing.
Okay.
But long term, the goal is to manage the condition
Right.
and reduce the risk of those dangerous events happening again.
Okay.
And that usually involves a combination of lifestyle changes, medications, and sometimes implantable devices.
Okay, so let's break down those long-term strategies.
Sure.
What kind of lifestyle changes are recommended?
We would tell them to avoid strenuous exercise
Okay.
or competitive sports
Right.
because those activities can trigger sudden increases in heart rate
Yeah,
that can provoke arrhythmias.
makes sense.
We'd also recommend avoiding medications that we know prolong the QT interval. They might need to review their medications with their doctor or pharmacist.
So it's all about minimizing those things.
Yeah.
That could put extra stress on the heart.
Exactly.
Okay, what about medications? What are the go-to drugs for managing long QT?
Usually the first choice is beta blockers. They block the effects of adrenaline on the heart,
Okay.
help stabilize the rhythm,
Right.
and prevent those sudden spikes in electrical activity
Yeah.
that can trigger arrhythmias.
So they keep the heart from getting too revved up.
Exactly.
Are there other medications we might consider?
Sometimes we might also prescribe sodium channel blockers, which slow down the heart's electrical conduction.
Right.
The choice really depends on the individual patient,
Right.
their specific type of long QT,
Hmm.
and their overall health.
So it's personalized medicine,
Exactly.
tailored to each patient's needs.
Mm-hmm.
What about those implantable devices? When would we use those?
For patients who are at very high risk
Okay.
of life-threatening arrhythmias,
Hmm.
we might recommend an implantable cardioverter defibrillator.
Okay.
or ICD for short.
And that constantly monitors the heart rhythm.
Exactly.
And if it detects a dangerous arrhythmia, it delivers a shock to reset the heart.
Exactly.
That's incredible.
Yeah.
It's like having a built-in safety net.
It is. It provides that peace of mind,
Right.
knowing that there's a system in place to protect them
Yeah.
if those dangerous rhythms happen.
Okay. But of course, the best approach is to prevent those arrhythmias from happening in the first place.
Yes.
Which is why those lifestyle changes, medications, and regular checkups are so important. Great. So we've covered 2 major heart rhythm disorders you need to know for the MCCQE, AV block and long QT syndrome.
Yes.
But there's another interesting condition that comes up on the exam.
Yes.
And it can be a little tricky to grasp. Are you ready to dive into Wolff-Parkinson-White syndrome?
Oh, yeah. Let's unpack WPW.
Okay, so Wolff-Parkinson-White, what is it all about?
WPW is interesting because it involves this extra electrical pathway in the heart, almost like a shortcut that bypasses the normal AV node.
Okay.
And this pathway can cause electrical signals to loop around, leading to these rapid heartbeats we call supraventricular tachycardia, or SVT.
So instead of the signal taking the usual route, it takes a detour.
Exactly.
And that messes up the heart's rhythm.
And because this pathway can conduct impulses so quickly, it can trigger those SVT episodes.
Okay.
So people with WPW might have palpitations, dizziness, shortness of breath, even syncope during those episodes.
Wow, it sounds like WPW can really disrupt a person's life.
It can, especially if those episodes are frequent or severe.
What causes this extra pathway to form in the first place?
It's usually congenital,
Okay.
meaning present at birth,
Right.
often because of a little developmental difference in the heart's wiring. Think of it like a tiny misconnection with potentially big consequences.
So a subtle difference in the anatomy leading to those dramatic arrhythmias. And you mentioned earlier that not everyone with WPW has symptoms.
Right. Some people might never even know they have it. It might be found, incidentally, during a routine ECG or when they're being checked for something else.
Makes sense. But for those who do have symptoms, especially those rapid heartbeats, it's important to get diagnosed and treated.
Absolutely.
So let's talk about diagnosis. How do we spot WPW on an ECG? Are there any telltale signs?
The ECG is our go-to for diagnosing WPW.
Okay.
There's a classic triad of findings that we look for.
Okay.
First, you'll see a short PR interval, showing that the signal is bypassing the AV node and taking that shortcut.
Right.
Second, there's a slurred upstroke of the QRS complex.
Okay.
We call it a delta wave.
A delta wave, it sounds like something you'd see on a seismograph measuring earthquakes.
You're not far off. It does look like a little bumper wave at the beginning of the QRS complex.
Right.
And lastly, you'll see a widened QRS complex reflecting that abnormal pathway.
So we're looking for that short PR interval, the delta wave, and a widened QRS complex.
Exactly, the WPW trifecta.
I like it, the WPW trifecta.
Yes.
Okay, so we've confirmed the diagnosis. How do we manage WPW?
Again, it depends on how bad the symptoms are and the individual patient.
Okay.
For some people with WPW who don't have many symptoms or have mild symptoms, we might just watch them closely and talk to them about lifestyle changes to avoid triggering those SVT episodes.
So sometimes a conservative approach is appropriate, especially if it's not really affecting their lives that much.
Yeah.
But what about those with more frequent or severe symptoms or those who have had dangerous arrhythmias?
Then we have a few tools we can use.
Okay.
There are medications that can help control those fast heartbeats. But the gold standard for treating WPW is catheter ablation.
Catheter ablation, that sounds pretty high-tech.
It is. It's a really precise procedure.
Okay.
A cardiologist puts a thin, flexible tube called a catheter into a vein, usually in the groin or arm, and guides it up to the heart. Then they use radiofrequency energy to destroy that tiny bit of extra tissue that's causing the problem.
So they're zapping away that rogue electrical circuit.
Exactly.
Getting rid of the shortcut that's causing all the trouble.
Exactly.
And how successful is this procedure?
It's very successful.
Okay.
For a lot of people, it's a cure.
Wow.
They can completely get rid of their WPW symptoms and live a normal life without worrying about those fast heartbeats.
That's amazing. It's incredible how far we've come in treating these conditions.
It really is.
It shows how important it is to stay up to date on all the latest treatments.
Absolutely. And the MCCQE will definitely test you on that.
For sure. Now, before we wrap up our discussion on these heart rhythm disorders, I want to talk about something crucial for the MCCQE.
Okay.
Being able to connect those textbook concepts to real-life situations.
Right.
It's not enough to just memorize facts.
No.
You have to be able to apply that knowledge to diagnose and manage real patients.
Absolutely. The MCCQE is all about testing your clinical reasoning skills.
Right.
Your ability to think like a doctor.
Right. Not just a med student who's good at memorizing.
Exactly.
So for our listeners who are preparing for the MCCQE, what advice would you give them for tackling those cardiology questions?
Don't get bogged down in memorizing every single detail.
Okay.
Focus on understanding the why behind the facts.
Right. Understanding the big picture.
Exactly.
How everything fits together.
And when you're doing practice questions, pay attention to the details in the question stem. There are often little clues that can help you narrow down the diagnosis or choose the best treatment.
That's like being a detective.
Yeah.
Looking for clues.
Exactly. And don't be afraid to draw diagrams or make notes as you're working through those questions. Visualizing those electrical pathways in the heart or mapping out the causes and treatments can really help you remember those concepts.
That's great advice.
Yeah.
I'm a big fan of using visuals to learn.
Me too. Another tip is to practice explaining these concepts out loud.
Okay.
Like you're teaching someone else that can help you figure out if you have any gaps in your understanding.
That's a great idea.
And make those complicated topics easier to digest.
Teaching is one of the best ways to learn.
For sure.
And remember, the MCCQE is just one step on your journey as a physician.
Yeah.
It's important to take care of yourselves. Manage stress. And remember why you chose this path.
Absolutely. It's about the passion for medicine, the desire to care for others, and always learning.
Yeah.
The MCCQE is just a checkpoint along that path.
Okay, so let's shift gears a bit.
Sure.
And talk about some specific clinical scenarios that could come up on the MCCQE related to these heart rhythm disorders.
Sure.
Imagine a patient comes into the ER complaining of palpitations and dizziness.
Okay.
What are the key questions you'd want to ask?
It's all about taking a systematic approach.
Okay.
First, I'd want to know about their palpitations.
Okay.
Are they fast, regular, irregular, forceful, fluttering?
Right.
When did they start? How long did they last? What triggers them?
So getting a really detailed history of their symptoms is important.
Very important.
What else would you want to know?
I'd ask about any other symptoms they're having.
Okay.
Like chest pain, shortness of breath, fainting.
Right.
We need to know if those symptoms point to a more serious problem.
And then, of course, I'd ask about their medical history.
Yeah.
Any medications they're taking.
Right.
And their family history.
Okay.
Especially any heart conditions.
So a thorough history is like building a foundation for the assessment.
Exactly.
What about the physical exam? What would you be looking for in this patient?
I'd check their heart rate and rhythm very carefully.
Okay.
Listening for any murmurs or extra sounds. I'd also check their blood pressure.
Okay.
And look for signs of poor perfusion.
Right.
Like pale skin or cool extremities. Those could indicate that the arrhythmia is affecting their circulation.
So you're gathering clues from the history and the physical exam.
Yes.
But the ECG would be crucial to confirm the diagnosis.
Absolutely. It's our gold standard for figuring out the specific type of arrhythmia.
Let's say the ECG shows a prolonged QT interval.
Okay.
What are some red flags that would make you think it's a more serious type of long QT that might need immediate treatment?
If they're faint.
Especially if it happens during exercise or stress.
Right.
That's a big red flag. Also, a family history of sudden cardiac death, or if their QTC is significantly prolonged. Those are warning signs that we need to act quickly.
So we need to be able to recognize those high-risk features that suggest a higher chance of developing those life-threatening arrhythmias.
Exactly.
What would you do to stabilize a patient like that?
We'd immediately address any reversible causes, like electrolyte imbalances.
Right.
We'd also think about starting them on beta blockers to help stabilize the rhythm and reduce the risk of those dangerous arrhythmias.
And in some cases, we might even recommend temporary pacing.
Yeah, to provide extra support while we're figuring out the cause of their long QT.
So it's a multifaceted approach.
Exactly.
Combining immediate interventions to stabilize the patient with long-term strategies to manage the condition.
It's all about tailoring the approach to each patient.
Right.
Thinking about their presentation, their risk factors, their overall health.
Right, and that's what the MCCQE is all about. It's testing your ability to apply your knowledge to real situations.
Exactly, to think critically.
Yeah.
And to make good clinical decisions.
Okay, so let's change gears for a second.
Sure.
And talk about a common challenge that students
face when prepping for the MCCQE The sheer volume of information.
Yeah, it can be overwhelming.
Oh,
Especially with complex topics like cardiology.
right?
So what advice would you give to students who are feeling kind of bogged down?
I would say, first of all, don't panic.
Right.
It's normal to feel overwhelmed by
Yeah.
all that medical knowledge. The key is to break it down into smaller pieces.
Right.
Focus on understanding the core concepts. Don't try to memorize everything.
So prioritize.
Yeah.
And focus on those high-yield topics.
The ones most likely to show up on the exam.
Exactly. And don't be afraid to use different resources that can help you learn better.
There are some great textbooks, review books, online question banks, even podcasts like this one that can make those tricky concepts easier to understand and more interesting.
For sure. There are so many tools out there now that can help make studying more efficient and even fun.
Absolutely.
And remember, the MCCQE isn't just about testing your knowledge. It's about evaluating those clinical reasoning skills.
Right.
Your ability to think critically and apply your knowledge to solve problems.
Exactly.
So as you're studying, try to focus on the why behind the facts.
Not just the what.
Exactly. And don't forget to take care of yourself.
Yes.
Get enough sleep, eat well, exercise, find ways to de-stress.
Absolutely. Burning yourself out will only make it harder to learn.
Makes sense. It's all about finding that balance between focused studying and taking care of your well-being.
For sure.
And speaking of balance, we've talked a lot about the electrical side of the heart, but the MCCQE also covers the structural parts.
That's right. And there's some fascinating conditions that can happen when those structures aren't working properly.
Yeah, like aortic stenosis.
Aortic stenosis, exactly.
It's a classic valve problem that we often see in older adults. It can start with very subtle symptoms, but it can lead to serious complications if it's not treated.
Absolutely. And it's a perfect example of a condition that might come up on the MCCQE.
Okay.
Testing your knowledge of both the pathophysiology and how it presents.
So let's dive into aortic stenosis.
Okay.
What's going on in this condition?
Aortic stenosis is basically a narrowing of the aortic valve.
Okay.
The valve that controls blood flow from the left ventricle out to the body.
So like a bottleneck.
Exactly. It restricts the flow of blood. And as that valve gets narrower, the heart has to work harder to pump blood through that smaller opening. And this can put a big strain on the left ventricle, eventually leading to hypertrophy.
Hypertrophy, that's the thickening of the heart muscle.
Exactly.
Well, one problem leads to another.
Precisely. And as the left ventricle keeps working overtime, it can start to weaken. And that can ultimately lead to heart failure.
Okay, that sounds serious.
What are the typical symptoms of aortic stenosis?
The tricky thing is it can be a silent killer, especially early on.
Right.
Many people don't have any noticeable symptoms for years.
Wow.
Even as that narrowing gets worse.
Okay.
But as it progresses, they might start to feel tired, short of breath, have chest pain, or even syncope, especially when they exert themselves.
So pretty general symptoms that could be caused by a lot of things. How do we know it's aortic stenosis?
That's where the physical exam is so important.
Right.
We listen carefully for heart sounds.
Okay.
And with aortic stenosis, you typically hear this characteristic murmur. A whooshing sound caused by the turbulent blood flow through that narrow valve.
So that murmur is a big clue. It is, but of course we need to confirm the diagnosis with more tests.
Right. What would we do?
An echocardiogram is the gold standard.
It makes sense.
It lets us actually see the valve, how severe the narrowing is, and the impact on the heart's structure and function.
It's like getting a detailed ultrasound of the heart.
Exactly.
Okay, so we've diagnosed aortic stenosis. What are our options for managing it?
Like most heart conditions, the treatment depends on how severe the stenosis is and the patient's overall health.
Okay.
In mild cases, we might just monitor them closely.
Okay.
Watch for any signs that it's getting worse.
Makes sense. But what about as the condition gets worse?
Then we need to think about more definitive treatments.
Like what kind of treatments?
For a long time, the only option was open heart surgery to replace the damaged valve with a prosthetic valve.
Right.
But in recent years, a less invasive procedure called TAVR has become a game changer.
TAVR, I've heard of that. How does that work?
It's a minimally invasive procedure.
Okay.
We insert a catheter through a blood vessel, usually in the groin or chest, and guide it up to the heart.
Okay.
And then a new valve is deployed through that catheter. replacing the damaged valve.
Without open heart surgery.
Exactly.
So it's much less invasive, which means faster recovery and fewer complications.
Exactly. TAVR has really changed how we treat aortic stenosis, especially for older patients or those who are too frail for open heart surgery.
It's amazing how medical technology is always advancing.
It really is.
Offering new options for patients.
And the MCCQE will expect you to know about these advances and understand when to use them.
Okay, let's talk about another structural abnormality that can affect the heart.
Sure.
Mitral valve prolapse.
Mitral valve prolapse.
Have you seen this in your practice?
Oh, yes.
Okay.
Mitral valve prolapse is pretty common. Affects about 2% of the population.
Wow.
It's often benign. But sometimes it can lead to complications that need medical attention.
So let's break this down. What exactly is happening in mitral valve prolapse?
So the mitral valve is the valve that separates the left atrium from the left ventricle. In mitral valve prolapse, one or both of the valve leaflets, those little flaps that control blood flow, bulge or prolapse back into the left atrium when the ventricle contracts.
So the valve isn't closing properly.
Exactly.
And some blood leaks back into the atrium.
That backflow of blood is called mitral regurgitation.
Okay.
In most cases, it's a small amount and doesn't cause any symptoms. But in some cases, it can be more significant, leading to fatigue, shortness of breath palpitations, even chest pain.
So it can range from mild and not noticeable to more severe cases that need treatment.
Exactly.
So what determines whether mitral valve prolapse will cause problems?
A few things.
Okay.
How severe the prolapse is, how much regurgitation there is, and whether there are any other complications like arrhythmias or endocarditis.
So it's not a one-size-fits-all condition?
Nope. Each case is different.
Okay, and that's something the MCCQE will test you on?
Yes.
That ability to individualize patient care?
Absolutely.
Okay, so how do we diagnose mitral valve prolapse?
The stethoscope is our first tool.
Okay.
We can often hear a clicking sound during the heartbeat caused by that prolapsing leaflet snapping back into place.
So those sounds can give us clues?
They can.
But we need an echo to confirm.
Right. The echocardiogram is the best imaging test for mitral valve prolapse.
Okay.
It lets us see the valve in action, how much prolapse and regurgitation there is, and check for any complications.
So we've covered diagnosis. What about treatment?
In many cases, we don't need to do anything. If it's mild and the patient doesn't have symptoms, we might just monitor them.
Okay.
Watch for any changes.
What if the prolapse is more severe or the patient has symptoms?
Then we might recommend medications to manage those symptoms.
Right. Like what kind of medication?
Beta blockers to control palpitations or diuretics to get rid of excess fluid.
So those meds help with the symptoms.
Oh, yeah, exactly.
But what if the prolapse is so bad that it's causing a lot of regurgitation or other problems?
Then we might need to think about surgery.
Okay.
Repair or replace the valve.
Right.
That decision depends on a few things. How severe the prolapse is, how much regurgitation there is, if there are any complications, and the patient's overall health.
It's a big decision.
It is weighing the risks and benefits for each patient.
You mentioned endocarditis earlier. What is that?
Endocarditis is an infection of the heart valves.
Okay.
It happens when bacteria or other microorganisms get into the bloodstream and attach to the valves, causing inflammation and damage. People with mitral valve prolapse, especially those with regurgitation, are at higher risk of endocarditis.
Why is that?
Because that abnormal valve makes it easier for bacteria to stick.
So it's like a weak spot.
Exactly.
That's more likely to get infected.
And endocarditis can be really serious, even life-threatening.
So what do we do?
We often recommend antibiotics for patients with mitral valve prolapse before they have certain dental or surgical procedures that could introduce bacteria into the bloodstream.
So it's a preventative measure to protect those vulnerable patients. And it reminds us that as doctors, we need to think about preventing future problems.
Absolutely.
Not just treating the current one.
Preventative medicine is so important.
Okay, let's move on to another common heart condition that you'll definitely see on the MCCQE, congestive heart failure.
Congestive heart failure.
It affects so many people.
It does.
And can really impact their quality of life.
Yeah.
So what exactly is happening and congestive heart failure?
It's basically a condition where the heart can't pump blood effectively enough to meet the body's needs.
And what causes that?
It can happen for a lot of reasons. Damage to the heart muscle from a heart attack, prolonged high blood pressure, or valve problems like the ones we've been talking about.
So it's often a result of other underlying conditions that damage the heart.
Exactly.
What are some of the typical symptoms of congestive heart failure?
The symptoms can vary depending on the severity and type. But some common ones are shortness of breath, fatigue, and swelling in the legs and ankles.
Those are pretty general symptoms.
Yeah.
What would make you suspect heart failure?
There are a few key signs. Shortness of breath that's worse when lying down is a classic sign. This happens because fluid backs up into the lungs when the heart isn't pumping well.
Like a plumbing problem.
Exactly.
Fluid building up in the wrong places. What else would you look for during the exam?
I listen to the heart and lungs, checking for any abnormal sounds, like a crackling sound in the lungs. That could mean fluid buildup. Swelling in the legs and ankles is another sign that the heart isn't keeping up.
So you're gathering information from their history, their symptoms, and the physical exam.
Yeah.
What tests would you do to confirm the diagnosis?
The echocardiogram is our go-to.
Right, the echo.
It shows us the heart's chambers and valves, how well it's pumping, and how severe the heart failure is.
And we might also order blood tests.
Yes, to check for markers of heart failure, like BNP.
Okay, so it's a combination of imaging and lab tests that help us understand the patient's condition.
Exactly.
Okay, so we've diagnosed heart failure. How do we manage it?
The goal is to make the heart pump better, reduce symptoms, and slow the progression of the disease. This usually involves lifestyle changes, medications, and in some cases, more advanced therapies.
All right, let's go through each of those.
Sure.
What kind of lifestyle changes are recommended?
One of the most important is a heart-healthy diet. Low in sodium and saturated fats. Reducing salt intake can help decrease fluid retention, which is a big part of those uncomfortable symptoms.
So diet is really important.
It is.
What else can patients do?
Regular physical activity is key. As long as they can tolerate it, it strengthens the heart muscle and improves its pumping. We would adjust the exercise recommendations based on each patient's abilities.
Makes sense. And what about smoking?
Oh, smoking is terrible for the heart and lungs. It can make heart failure symptoms much worse. Quitting is one of the best things a patient can do.
So it's all about empowering patients to take charge of their health.
Exactly.
Through these lifestyle changes. Okay, what about medications? What are the main drugs used for heart failure?
We use several types of medications. ACE inhibitors and ARBs. They help lower blood pressure and reduce the workload on the heart. Beta blockers can slow the heart rate and improve its efficiency. And diuretics help get rid of excess fluid.
Reducing swelling and shortness of breath.
Exactly. So each type of medication targets a different part of the problem.
We often use them in combination.
We do. The specific combination depends on the patient, how severe their heart failure is, and any other medical conditions they might have.
So it's personalized treatment.
Absolutely.
What about those more advanced therapies? Cardiac resynchronization therapy or a left ventricular assist device?
Those are usually for patients with more advanced heart failure who aren't getting better with just meds and lifestyle changes. Cardiac resynchronization therapy involves implanting a device that helps coordinate the heart's contractions so it pumps better. An LVAD is a more complex device that basically acts as a mechanical pump, helping the weakened left ventricle.
Those are amazing advancements.
They are.
That can really improve quality of life for these patients.
Absolutely.
And the MCCQE might ask you about them.
It might.
Testing your knowledge of when to use them.
And any potential problems with them.
Okay, so we've covered a lot today.
We have
some really challenging cardiology concepts. But before we wrap up, I want to emphasize one last thing. The importance of staying calm and focused during the exam.
Oh, that's so important.
It's a high-stakes exam.
It is.
It's normal to feel anxious. But remember, you've worked hard, you've studied a lot, and you're prepared.
Trust in your knowledge and your skills.
Exactly. And if you start to feel flustered, take a deep breath. Remind yourself of all the work you've put in.
Right.
And approach each question systematically.
Like we've talked about today.
Break down those complex questions. Focus on the key information.
Yeah.
And use your clinical reasoning skills to get to the right answer.
The MCCQE is just one step on your journey as doctors. It's challenging, but it's not everything.
Right. The most important thing is to stay true to your passion for medicine, your commitment to learning, and your dedication to providing the best care to your patients.
Absolutely.
Okay. So, with that, I think it's time to wrap up.
Yeah.
Thanks for joining us for this deep dive into cardiology.
It's been a pleasure.
Until next time, happy studying.
So let's talk about another condition that pops up a lot on the MCCQE, heart failure.
Heart failure.
It's a complicated syndrome, but understanding the basics is key for doing well on those exam questions, and even more important for taking good care of patients.
Heart failure. Sounds pretty straightforward, but I know it's more complicated than the name suggests. What's the easiest way to explain what's happening when someone has heart failure?
You're right. Heart failure can be a little misleading. It doesn't mean the heart just stops working. It means the heart's not pumping blood as well as it should.
Okay, so it's like a pump that's losing power. What makes that pumping ability go down?
Lots of things can contribute: coronary artery disease, hypertension valve problems, like the ones we talked about earlier. All those things can damage the heart muscle over time and lead to heart failure.
So it's often a result of other things that take a toll on the heart's ability to work properly. What kinds of symptoms would someone with heart failure usually have?
It depends on how severe it is and what type of heart failure they have. But some common symptoms are shortness of breath, fatigue, swelling in the legs and ankles.
Those sound pretty general. What would make you think it might be heart failure?
There are a few clues. Shortness of breath that gets worse when lying down. That's a classic sign of heart failure. It happens because fluid backs up in the lungs when the heart isn't pumping well.
So it's kind of like a plumbing problem, fluid building up where it shouldn't be. What else would you look for during a physical exam?
I'd listen carefully to the heart and lungs, checking for any abnormal sounds. Crackling in the lungs could mean fluid buildup, and swelling in the legs and ankles is another sign that the heart isn't doing its job properly.
So you're looking at their history, their symptoms, what you find on the exam, but you need to do some tests to be sure. What's the most common test for diagnosing heart failure?
The echocardiogram, that's our go-to. It shows us the heart's chambers and valves, how well it's pumping, how bad the heart failure is.
Right, the echo gives us that detailed picture. Okay, so we've got the diagnosis. How do you usually manage heart failure?
We want to improve how the heart pumps, reduce symptoms, slow down how fast the disease gets worse. This usually involves lifestyle changes, medications, and sometimes more advanced therapies like the ones you mentioned before.
Let's talk about each of those. What kinds of lifestyle changes can help someone with heart failure?
One of the most important is eating a heart-healthy diet. Low in sodium and saturated fat. Cutting back on salt can really help reduce fluid retention, which is a big part of those uncomfortable symptoms.
So diet makes a big difference. What else can people do to help their heart and manage symptoms?
Regular exercise is important, as long as they can handle it. It helps strengthen the heart muscle and improve how well it pumps. Of course, we'd adjust the exercise plan based on what each patient can do.
Right. It's about finding that balance. What about smoking? I'm guessing that's a no-go.
Absolutely. Smoking is really bad for the heart and lungs. Makes heart failure symptoms way worse.
Yeah.
Quitting smoking is one of the best things someone with heart failure can do.
So it's about helping people take control of their health through those lifestyle changes. What about medications? What are the usual drugs prescribed for heart failure?
We use a few different kinds. ACE inhibitors and ARBs. Those help lower blood pressure and reduce the strain on the heart. Beta blockers can slow down the heart rate, which lets the heart fill up more completely and pump better. And diuretics get rid of extra fluid, reducing that swelling.
So each kind of medication works on a different part of the problem, and you often use them together.
We do. The combination depends on the patient, how bad their heart failure is, any other conditions they have.
Right. So it's tailored to each person.
What about those more advanced therapies, like cardiac resynchronization therapy or an LVAD? When would you use those?
Those are usually for people with more severe heart failure who aren't getting better with just meds and lifestyle changes. Cardiac resynchronization therapy involves putting in a device that helps the heart beat in a more coordinated way so it pumps better. An LVAD is a more complicated device that basically acts like a mechanical pump, taking over for the weak left ventricle.
Wow. Those are incredible. They can really be lifesavers for people with serious heart failure. The MCCQE might ask about them. Definitely. It will test if you know when to use them and what the risks and benefits are.
So we've talked about a lot of important cardiology concepts today, things you'll need to know for the MCCQE. But before we go, I want to say one last thing. It's so important to stay calm and focused during the exam.
Such good advice, Harvey. The MCCQE is a tough exam. It's normal to feel anxious, but you've studied hard. You're prepared. Believe in yourself.
Exactly. And if you start to get stressed, take a deep breath. Remember all the work you've put in. Go through each question step by step, like we've talked about.
Break down those hard questions. Focus on what's important. Use your clinical reasoning skills to find the best answer.
Remember, the MCCQE is just one step on your journey to becoming a doctor. It's tough, but it's not the only thing. The most important thing is to hold on to your passion for medicine. Keep learning. Be dedicated to taking great care of your patients.
Well said, Harvey. And with that, I think we'll wrap things up for today. Good luck to everyone listening on their MCCQE journey.
Until next time, happy studying.